Okay. Thank you all for joining us today. Opal Greenway will be our presenter with Stroudwater, and she's going to be covering provider contracts, a changing environment, things to be thinking of when you renew contracts or if you're setting up a new contract with a provider. As always, we try to be as informal as possible. So if you have any questions, you have control over muting and unmuting yourself. So you can feel free to blurt it out. If you put it in the chat, I'll be watching the chat. I've already hit the record button. We will be recording this and making it available on our YouTube channel, hopefully later this week. So with that said, Opal, I'll turn it over to you.
Thanks, Laura, and thanks everyone for joining us today to go over provider contracts. So today we're going to be going over basically the environment that has created what is going on with compensation and these contracts. It's a heavily regulated and very complex environment. It's not as straightforward as say, okay, here's your salary divided by 26 payroll periods and writing out a check from that standpoint. And unfortunately, there's a lot of dynamics that are impacting compensation, some of which are actually related to CMS and regulatory changes, as well as the COVID impact of last year. So we're going to go over what really the things that have transpired in the past 12 months and how those are impacting our provider contracts, things we need to take into consideration, documentation we need to have in place. And then we're going to be talking about basically where do we go from here? What is our takeaway of my to-do items when I get off of this call, and thinking about the overall compensation strategy going forward for my organization, because realistically, we don't want to be in a situation where you're constantly having to change your contracts, constantly having to blow up your compensation structure, because it really negatively impacts the provider hospital alignment. And doing that on a regular basis, that's just not something people want to go through. So we want to talk about how setting up a compensation strategy will set you up for being able to go through the changes that are coming forward in future years, as well as dealing with today's changes without having to go through and completely redraft things over and over again. So starting off talking about the overall environment and how complex and heavily regulated it is, we also have to think about just why do we even care from that standpoint? If you're not a lawyer, who cares that it's all this heavily regulated? And the reality is, when we look at what actual physician spend is in an organization, it's 5 to 10% of your net patient service revenue from that standpoint. Well, with the rural hospitals that we work with at Stroudwater, we see that, and that's just the physician spend. Our hospitals tend to have a lot of advanced practice providers that they're utilizing, so that spend is significantly higher than the 5 to 10%. So it's usually one of our biggest buckets of expense on our P&L. On top of that, we look at that bucket of salaries and wages and benefits on our P&L, and hopefully we're breaking it out where we can see directly what's related to the provider. But that's not the only bucket where this spend lives. There's other parts of the P&L that incorporate these expenditures that oftentimes people forget about. So when they're calculating their ROI and thinking about investment decisions for providers, they might be missing the boat as to how am I appropriately calculating my ROI for these providers and what should be my investment decisions, because things such as your independent providers might be sitting in contracted services because they're under a professional services agreement. Your locum tenens might be underneath contracted services. Things such as CME that are an education expense but are part of the overall provider spend are oftentimes not included in salaries, wages, and benefits. They lay in other parts of of your P&L. Depending on how complex your compensation structure is and what is listed in your contracts, there's several components of the physician's salary and wages, such as productivity bonuses, that might be calculated elsewhere, or quality payments. So when you think about how do I compare overall and what percentage of my net patient service revenue really is tied to my provider spend, am I getting the appropriate ROI for that? You really actually need to be working with your finance team to dig deep and make sure what are all the different sources of this provider spend and where is it currently located on my operating statement, and how can I pull that out to appropriately allocate and account for that in future decisions. And I think that's an important part of how you have the conversations with the providers, is understanding this is a huge investment for any organization. And so it's important that we engage with providers about the investment that we're making in them and how we can collaborate to make sure that is worthwhile for everyone. Now, from a regulatory perspective, other people, oftentimes the CFO of our hospitals, are thinking about, well, in addition to looking at it from a huge spend, I do need to make sure I'm in compliance. And the compliance law that most people come to mind when it comes to provider compensation is the Stark Law, right? Under the Stark Law, that really regulates any sort of remuneration that is paid between a physician and any organization that they have the ability to make a referral to is the fair market value standard. Most people are familiar with fair market value in the standpoint of they think, okay, I need to make sure whatever I pay the doctor or pay the nurse practitioner falls within market, right? It seems like it's very common sense. However, as we'll get into, fair market value is more complex than just saying, okay, is it within market? Does it fall with MGMA median from that standpoint? A component that some people miss is that whatever your remuneration that you're paying has to also be commercially reasonable. So what does that mean? Because there's been a lot of people who thought, how could it be when they hear commercially reasonable, they think it makes good business sense. Well, how could it possibly be good business sense to lose money in a physician clinic? As we know, the vast majority of clinics that we are working with, even if they're a rural healthcare clinic and they're getting the benefits of cost-based reimbursement, are technically losing money in that department, right? They may be making up for it elsewhere with downstream revenue, but the clinic itself is losing money. So how could that possibly be commercially reasonable? The answer is you don't have to be commercially reasonable does not translate into needing to be profitable. That is not the same thing. So when we think about what's commercially reasonable, we think about how does this from a compliance standpoint, is it meeting the needs of our community? Does it make sense for a community to have this service? So several of you guys, if you're a not-for-profit entity, have to have a community health needs assessment done and understand what are the actual needs of my community and how am I fulfilling those? And is this the best way, or am I doing it in a commercially reasonable way? Am I a small hospital in Oklahoma and with a population that I'm serving of 15,000? Am I going through and deciding I'm going to add an infectious disease specialist that focuses on blood infectious diseases and blood transplants? Probably not. That's something that might not be commercially reasonable for you to provide. But it also comes into play when we think about doing the comparison of, for example, a lot of rural hospitals might have a general surgeon. They may have multiple general surgeons because of the increasing difficulty to recruit a general surgeon to do 24/7 call or even a 1 and 2 call. So we might need to do 1 and 3 call. Does it make sense for your hospital? Is it commercially reasonable for them to have 3 general surgeons? The answer, of course, is going to be it depends. What is the situation for your community? Is it something where you do have enough volume to support a full-time general surgery program and the cost of locum tenens make it unreasonable where it's actually more commercially reasonable to have 3 providers when the community only needs maybe 1.7 FTEs? That might be commercially reasonable. However, if you really only have daytime surgery and there's another hospital where you only have surgery 2 days a week, it's probably more commercially reasonable to have a professional services agreement in place and have that type of contract to have a part-time provider rather than to try to have 3 general surgeons. And unfortunately, in our experience, there's lots of organizations that are not going through and doing that full exercise. It's what has always been. We've seen volumes drop, we've cut back on services, and we don't go back and think, well, we've had this provider in the community for a long time. Are we still doing it in the best way possible that it still fulfills the commercial reasonableness test? And then the last part of Stark is the fact that you're not supposed to be paying for volume or value of referrals, right? And that seems to be the really obvious one. If you're like, well, if I'm not paying for referrals, I should be fine under Stark. But the reality is, it's really expensive to not make sure you're not doing that. Yes, you may not have specific language in your contract that says you're paying for referrals, but there might be other technical violations within how you have your contract set up that can be highly problematic for your organization. So here I'm showing the cost of compliance for some organizations. And a lot of people, when they hear the big news about a Stark or an anti-kickback violation, they're assuming it's tenant or their end. And I don't mean to pick on tenant. They just had there was a lot of press about them a few years ago with hundreds of millions of dollars of settlements that had to get paid. But that's what people think of. They don't think, oh, could my small rural hospital even possibly be at risk of having a Stark or anti-kickback? They're not focused on me. They're not focused on the rural, small, independent hospitals. They have to be focused on the large, deep pockets. That's not necessarily the case. Just last year, a hospital about an hour and a half north of me in Tennessee did have a false claims allegation and had to settle it for $4.1 million. There was nothing intentional done there. They thought they were doing things right, but frankly, they weren't double checking. They weren't being precise. They weren't going through the full compliance checklist of what they needed to do. And as a consequence, they had some serious penalties. And when we think about these penalties, our hospitals that are here on this call today, realistically, we're not talking about a $4 million penalty or even a $1.6 million penalty that will hurt us. A $500,000 penalty could mean making payroll for some of our hospitals, And when you think about what the penalties are, realistically, they are tied to every single Medicare payment and sometimes Medicaid payment for the entire life of the contract. So you think about some of your provider contracts. You might have a contract that we've seen several that are over 5 years old since the last time they were looked at. I have contracts that are not well documented, that it was a handshake 20 years ago. So the contract doesn't even exist from that standpoint. But the reality is every single Medicare payment that was made during the entire life of the problematic contract. So when you think about that, that's part of why it's important in good hygiene to make sure you're looking at your contracts on an annual basis and doing appropriate updates so that you don't have such increased exposure for something that was happened years ago, because there's no limit of how far that look back can go, except for it's tied to the life of the contract. On top of that, there's specific penalties per violation on top of having to pay back the Medicare payments. So you can see how that can really easily add up and be very problematic for our rural hospitals. On top of that, back in 2017, the OIG specifically stated that their focus when they were looking at what was going on with provider spend, provider compensation, a lot of people using just median levels. And when everybody pays median, and so it says, okay, I'm going to pay $10,000 over median, we're going to pay the 60th percentile. What does it do? It raises the overall median. And so when they were seeing that, they said, we need to have closer attention to this. We understand that there's a rural premium, but some people are getting out of control with this. So in 2017, they actually said, from here going forward, we're going to have an increased attention to what is going on with rural hospitals, and that not just hospitals that are part of larger health systems from that standpoint. So I don't want people to think, oh, I'm just a 15-bed hospital here. The likelihood that this is ever going to apply to me is so low. I don't need to be paying attention to this. Let's just get on to the compensation strategy. That this is just the lawyer on her soapbox. That is not the case. This is one where I've seen some of our rural hospitals having to pay $1 million or $750,000 that is really damaging to their overall bottom line. But people do ask me the question of, but how does anybody even find out about this? How do I end up in the hot seat? Should I really be worried about this or not from that standpoint? Realistically, the most common way that this comes up is usually it's a departing employee, a physician or a CFO. I have seen some that have been nurse practitioners where there's a whistleblower, that they knew that there was something that was up that didn't seem right from their perspective. And upon departing the organization, they raised the flag saying, you should do an audit of this, or you should pay attention to this. And so that's still the most common way that this happens. Sometimes it's from a competitor hospital, especially when, given the shortages that we have with providers, if two competing hospitals are going after the same physician group or the same provider. Oftentimes, if it's a practice acquisition, you've had a fair market valuation done to tell you what you can pay for the practice. And reasonable evaluators should come within 10% of one another. So if I'm hospital A and I'm trying to buy this physician practice, maybe it's, a 3 provider family practice, or it's a rural health clinic that I'm converting to being provider based. I have a valuation done and it tells me that I can pay $500,000 for that practice. And the physicians come back and say, no, we're going to go to this other competing hospital because they've offered us $1.7 million. Well, I have my valuation that says $500,000. How on earth? I know that there's no way I can pay 1.7. I'm not going to go shopping for numbers from evaluator to find a number that I like. How is that even possible? So those competing hospitals who are losing out on that bid often can be a whistleblower and raise the issue, because you can't see how my valuation from 500,000, somebody else paid 1.7 for the same practice. It wasn't reasonable. Some of these also happen because of patient complaints. That one happens not very frequently, but if somebody's not able to walk them through their bill and why they were referred for different labs, especially, I will say, where patient complaints lead to this is more often if providers or systems basically override a patient request to go and have their lab done, especially with the popping up of all these freestanding services. They want to go to the cheapest place available that can still provide the quality work. And then being insistent upon, no, you have to have it done at the hospital for whatever reason, and they don't give a good enough explanation. That's where we see some of the patient complaints. The thing that's a little bit more unique that we're starting to see more of is when you have an audit done that's triggered by unusual billing patterns, it is allowed to automatically be reviewed to allow them to look at compensation as well. So if you're having issues in your revenue cycle with your billers and coders, that shows some unusual events that you can't explain. Oftentimes, maybe you just switch from using a third-party vendor to coming in-house or something of that nature. It can possibly trigger a review of compensation. And so they uncovered some of these technical violations that way. So let's go back to thinking about what is fair market value. Because again, it's not just looking at the survey data and saying median is X and that's what I'm going to pay. Realistically, you have to think, what are you paying for, right? There's both the individual providers and the position that they're going to hold. What did you draft when you started looking for this provider from that position, right? What was their specialty or subspecialty? What are the duties and responsibilities they're going to have? Are you going to have them be a medical director or part-time CMO? From that standpoint, what are the hats that they're going to wear? What does the overall community need? Do we have wait times? Are we having 3 months out before somebody can come in and see, the next new patient visit or something of that nature? Do we have a high disease incidence? Do we have a significant amount of diabetes where maybe we do need an endocrinologist to be working with our diabetic population? Do we have seasonality that's happening or out-migration, with people leaving our communities? One of the things is if you are somewhere that might be close to a college and you use providers to provide services at maybe the local college, do you need more providers during a specific time of year when students are in session? Again, this might be a little bit more pre-COVID than current state with the use of virtual colleges now. But as they come back, are you going to need to recruit and coordinate with the college if students are going to be coming back online? Are you starting out a new specialty or service where there's a specific community benefit you're trying to use? So for those of you who do get your CHNA, I think that those are always a really great starting point for helping you document what is the fair market value? Why am I recruiting this provider? What does the market look like and what does my community need? So that's usually a very important piece of documentation that will help you with demonstrating why is this fair market value. Other pieces, how long did it take me to recruit that provider? The average recruitment time for a primary care provider is about 250 days. For a specialist, depending on the specialty, it might be over 400 days. So if you have an opening that you've been trying to fill and it's greatly exceeding the expectations of how long you thought it was going to take, that you can't even get a number of quality candidates to come in from interview, you need to look at, hey, maybe my fair market value is actually higher and I might have to spend more because I'm not getting any candidates in. Or I might need to look at the other forms of remuneration that I pay to be able to get somebody in. And then there's things that might be specific to the individual provider. What is their training and experience? Are you bringing in somebody who is right out of residency or somebody with 20 years of experience? One thing we've actually worked with for rural health clinics and rural health communities is the military has trauma surgeons that are trained general surgeons that have been working basically in the military and trauma situations. There are specific programs out there that the military has been helping these providers transition to civilian life, and they're a perfect fit for rural entities because they're used to practicing in an environment where they don't have expansive resources, that they don't have all these different specialists on hand all of the time. So they have a very different kind of training that is really appropriate for our rural communities than, say, getting somebody from, Vanderbilt University that's down the street from me in Nashville. That kind of provider, there's a premium that you can apply rather than somebody who's fresh out of residency and is used to calling the cardiologist if anything happens, because it expands what kinds of services you might be able to provide in your hospital. And then the other piece, of course, is the compensation methodology and the actual amount, right? Is that within market, given all these other factors? Is it something where, hey, we're going to give a base compensation for a couple of years and then we're going to put in productivity? Is it somebody that's going to be pure productivity? Are we doing a part-time provider where we're going to pay them a day rate? So thinking about this, if you step back and think, how have I documented how I'm paying my providers? I'm making sure I'm within fair market value. Which of these things have I looked at and paid attention to versus just what is the bottom line total salary that the provider's paying? And where is that documented? Is it in the contract? Is it in their file? Is it in some sort of other sort of documentation? Can I access it when I need it? Are really important things to think about from a fair market valuation perspective. So let's talk about the different types of compensation models that are out there that are creating, this environment. Most common that pretty much everybody is familiar with is the base salary, right? Oftentimes with a new provider, you have your annual guarantee. Best practice is to have that in place for 18 to 24 months as a provider is ramping up if they're a new provider. And then it should be adjusted regularly based on what the provider is actually doing, both their responsibilities, how productive they're being, and what other things you're having them do, whether it's quality, what other types of compensation you're putting into that. I really don't like structures that are annual guarantees that go on indefinitely, that are 5 years, 6 years, or things that never get reset. Because realistically, that is probably, the hospital is not getting a guaranteed amount every single year, regardless of how many patients they see or how the quality of their work from that standpoint. So if you think about it from that perspective, if you have an indefinite annual guarantee for a provider that's never readjusted based on how the hospital is getting paid, your alignment between your compensation and your reimbursement is really far off. So what we're constantly trying to do is bring that alignment better together between the hospital and the compensation. Another piece that most of you guys should be familiar with might be productivity incentive. It used to be popular to do a percentage of net patient service revenue or gross charges. There was a lot of reasons, especially with regards to payer mix and picking and choosing which patients you would see, that has really been replaced by compensation per work RVU is the most prevalent that we see. Now, my problem with just thinking, okay, let's do comp per work RVU because it's easy to assign, is with our rural hospitals, we might have a rural health clinic. And so we actually only get paid on the rural health clinic qualifying visits. So is the provider getting compensated per work RVU for work that they're doing that the hospital doesn't get compensated for? That's where we have to assess it from an alignment perspective. On top of that, realistically, specialty care and primary care are two different animals. We have to be able to recognize those two different animals and how they see patients, and where work RVUs are typically more appropriate for specialists, compensation per visit is more appropriate for a primary care provider. Or if you're far along in the value-based compensation range and getting reimbursement, it might be patient panel management. Another piece of compensation that we see is for administrative and or academic duties. The ones that you guys are most familiar with probably are medical directorships and APP supervision. APP supervision might be done as simply a stipend per APP, or for APP over, a set number that is considered standard for your community. Say most of your primary care providers, because you have multiple rural health clinics, they might be overseeing 3 APPs each. And so they get a stipend for the 4th or 5th APP that you add onto their docket of who they're looking at. And then the last piece is where more people we're trying to help them understand how to move to this compensation. But for most of our rural hospitals, they're not there yet, and they're trying to get there, is with regards to value-based compensation. So you might be very familiar with value-based compensation from the standpoint of giving an incentive for quality outcomes. Oftentimes, if you were previously on PQRS, you gave, here's your $5,000 stipend for hitting your certain goals. A step further from that is to actually tie it to how you're getting reimbursed and looking at it from what is your value-based reimbursement? Do you adjust their work RVU conversion rate up or down based off of how they're hitting certain metrics that tie to your reimbursement? Are you giving them a distribution of ACO dollars because of how they're documenting? And that contributes to what you're getting from the ACO. If you're participating in shared savings from that standpoint, do the providers get any sort of access to that bucket of money that comes from shared savings? And what is the manner in which you do it? Again, not as common yet for a lot of our rural hospitals, but definitely thinking about how do they get there as they see their reimbursement changing. So when we think about this transition that people are making over from fee-for-service to a population-based payment system and health system, you have to think about how your compensation will go along with that. Underneath a fee-for-service world, it makes a ton of sense to pay a lot of their compensation tied to productivity, right? The more patients I see, the more money that I make. Makes a ton of sense under fee-for-service. You can see that if you moved along this transition framework over to population health, that doesn't really make sense, because you as an organization, the more patients you see does not mean the more payments that you get from your different payers, right? So we think about how do we align our compensation to where we're at and where we're going. Realistically, HHS has said that they would like to see some sort of value-based contracts tied in to Medicare. Medicare, it's 50% by 2022, and 100% of contracts have some portion of this by 2025. Medicaid and commercial are following shortly thereafter. So if you think about it, we're in 2021, and if you have none of your contract tied to anything in value-based, if Medicare is able to actually accelerate this the way that they've been talking about doing, and we saw it with the macro, everything with macro coming out, where are we on our current compensation? If you're still on complete annual guarantees, it's going to be very difficult to be anywhere near getting value-based contracts in your compensation in the next 4 years. If you're already paying quality, you're closer to that. But realistically, this has been accelerating significantly over the past 10 years. So we need to think about how our contracts and our compensation fit in with that. So let's talk about the regulatory and COVID-19 impacts of how they've adjusted the compensation recently. One of the biggest ones that we see that is directly impacting your contracts and the compensation is what happened with the physician fee schedule, that I will say a lot of people who are in RHCs don't pay a ton of attention to if they're cost-based reimbursement. We don't spend a lot of time on the physician fee schedule. However, the physician fee schedule is what sets work RVUs for your CPT codes. And in December of 2020, they made a significant change. The whole purpose of the change, because we hadn't really had a big change since 2007, was to address the undervaluation of the E&M codes, especially paying attention to primary care, right? There's a huge documentation burden on physicians for having to do multi-system checks, treat the whole patient, move towards population health where we're doing patient panel management rather than just incident-based medicine. And as such, they significantly increased the value for the codes associated with your E&M for your new and established patients. When you look at it from a utilization rate on a weighted basis, it was an increase of 35.8% increase in work RVUs. If you build the exact same codes from one year to the next, the work RVUs would increase significantly. So, this is different based on the different specialties. So it highlights, right, the difference between specialists and primary care. You see those who are actually historically have been paid the most on a per work RVU basis, general surgery, orthopedics, etc. Their change in work RVUs are somewhat unaffected or more minimal, right? 3%, 6%, etc. Not something that if you were paying all these specialists on a per work RVU basis was too much of a cause for concern. But primary care, if you were paying under your contract, your primary care provider, say $50 per work RVU, and they bill the exact same visits from last year, 2020 to 2021, under the new physician fee schedule, you could expect an obligation of compensation increase of 19.3% for your family medicine. I don't know about any of you specifically, but I doubt you have that in your kitty to just say, okay, compensation's going up nearly 20%, no big deal, especially after we went through with COVID. Now, this wouldn't be such a huge deal if we knew that we were going to get a change in reimbursement commensurate with a change in work RVUs. Okay, we're going to get paid that much more. That's not the reality, especially for those that are cost-based. The payment compared to the work RVU are completely divorced, and so we're not going to get those increased payments. On top of that, there was changes in the RHC, so I'll get to that in just a moment. But I wanted to give this example. This is a primary care group that they're an independent group. They had a PSA with the hospital system. This is a primary care group where they were paid because under their PSA a per work RVU rate, $98.35. Right. This group wasn't significantly impacted by COVID at all, really. They were producing highly productive groups, six providers producing about 60,000 work RVUs on a total basis. So in 2020, getting $5.9 million from the hospital. If they changed to the 2021 fee schedule without changing any of their coding, without adjusting their work, just taking those CPT codes that they built in 2020 and use the 2021 schedule, you were seeing an increase from 60,000 to about 73,000 work RVUs. So the reality is the hospital is going to have to cut a check to the practice of an additional $1.3 million. Great for the docs, right? Hospital budget, there's nothing in the hospital budget that could have ever allowed for such an increase in payment. They don't have the money, right? From that standpoint, it's too big of a change drastically. In this case, they were expected to have an increase in revenue of about $600,000, but even so, it's still a significant negative impact for the hospital. So initially, in thinking through this, they came back to the practice and said, we can't afford this. Luckily, they were a very strongly aligned primary care group in the hospital. They're on the same page, great collaboration and partnership. So they came back, and so of course the practice recognized the reality of the financial situation. They're not thinking about it, well, I'm sorry, contractually you owe it to me, so cough up the money. So they proposed $80 per work RVU. Realistically, so we were engaged on the practice side of things, looking at, okay, what would be break even? The practice would significant for the hospital. The practice would significantly benefit. That would be 88 and 89 cents. What we agreed to, because there was such a strong alignment between the practice and the hospital, is like, let's split the difference as far as the increase of expected revenue. So that hospital, yes, you're going to pay us more, but not as much as you were originally obligated to underneath the contract. But we also get a share in the fact that you're going to have some increases in revenue. So we ended up coming at $85 per work RVU, a significant difference than the original outlay from the hospital of an additional $1.3 million. So that's just an example that was not an RHC situation, but it was, a great relationship between the hospital and a primary care practice. Now, the complication for the RHCs when they see these increases in work RVUs and potentially tied to their compensation is we had a change in our RHC reimbursement methodology. So we can't just lay the cost, that increased cost for our providers onto the RHC, depending on where we are on these visits. the previous strategy of being cost-based, and so being able to allocate all those costs and have it impact our visit rate doesn't work for us underneath the new laws with regards to RHC. And I think Jonathan recently did a far more detailed presentation going through all of these changes, but this change makes the need to pay attention to how this impacts your contracts all that much more important from that perspective, because you can't just transfer the costs over into getting an increased rate in your RHC. Another major regulatory change we had was with regards to the Stark Law that I started out talking about, right? I will say for most of our clients that are in rural communities, the changes into the Stark Law were not as significant as initially thought. So I'm going to just only spend time here on the direct referral safe harbor that was added, because this is one, when you think about your compensation strategy, might be really applicable to this group. So if you're thinking about your domestic leakage, right? Where are your patients leaving you for that you actually provide those services and you could provide it at your hospital? Right now, under the Stark Law, I would say in 2020, under the Stark Law, you previously couldn't force your providers really to make sure that they kept referrals in network, right? That you made your referrals to the hospital that they could. You might have a provider that you employ and they still send all their general surgery elsewhere, or they send certain labs, or they send certain other ancillary services to other locations. What you can do now under the direct referral safe harbor is actually tie some of the compensation based on a percentage basis to referrals, of saying what makes sense to stay here. Provider X, you can have access to your productivity incentive compensation as long as you make 70% of your appropriate referrals to this system. You can't do it as a direct volume or the value of referrals. So it can't be, hey, as long, for referrals that are worth over $50,000 to us, you have to make 100% of those. It has to be tied more indirectly, where it's like a percentage of your referrals have to stay in-house. However, you cannot impact patient preference, insurance preference, or patient's best medical interests. So realistically, when you say provider X, you need to make 70% of your referrals in network, that 70% of referrals needs to be tied to only applicable referrals. So if the patient prefers to go elsewhere and they state that, that can't be included in there. If the insurance, if you don't get prior authorization and the insurance says we don't work with you, we would prefer the patient go to this hospital, you can't include those referrals in your calculation. Or of course, if it's not in the patient's best medical interest. For example, a service that you don't provide or a service that someone else provides significantly better that is appropriate for that patient. The other part that came out with Stark, this wasn't a change in the law, but CMS came out with a statement that specifically said, when it comes to fair market value, you cannot rely on just saying survey says. So you can't have in your contract that basically says, we're going to pay you the 50th percentile no matter what, or 60th percentile no matter what. You can't just say that, because we see people all the time using the surveys incredibly inappropriately and not doing all that work that we were talking about. What if you give them the 50th percent and they're only producing at the 10th percentile? That doesn't make any sense. What if you say the 50th percentile and they're producing at the 90th percentile? Or there's all these other reasons, from that standpoint. So you can't just simply say, whatever the survey says is what we're going to pay you, right? And that's something that CMS had been scrutinizing, but they've never directly said it. This past year is the first time that they've very specifically stated it. So let's talk about COVID-19 and our fun subject of everything that we've all gone through for the past year and are still going through. Luckily, early on in the pandemic, they did issue Stark blanket waivers that allowed provider organizations to adjust their compensation to account for the reality that people were going through. We had most providers, we had services that were suspended. So if you were on a productivity base, you probably had a significant drop in compensation. We weren't doing surgery for a couple of months of any kind of elective surgery. We also came in and did different things such as allocation of resources, free office space, using, sharing with another organization equipment rentals. making sure we were keeping people whole who had reductions in productivity, providing free services, which people never think of as actual remuneration, but it is. So if we put our physicians in a hospital, if they had COVID exposure, to quarantine there rather than them go back and bring it home to their families and the hospital paid for the hotel, that's remuneration, right? Here's the key with the blanket waivers. They're great as long as you can tie it to COVID. You want to make sure you have it in place, but you do have to put it in writing. And luckily, you can do it in retrospect, right? You can write a memo right now that outlines, here's what I did with my provider compensation. Here's why I did it. Here's how COVID impacted it. And, have your attorney look at it, file it away, just so that you have it. Then the blanket waiver actually applies. If you don't document it, you could be subject to the Stark violations from that standpoint. So it is a documentation exercise, and you do have to actually get it in some sort of writing, signed, especially if you actually change the provider's contract. You needed to get it incorporated as part of their contract. But realistically, is put people in a situation where a lot of providers had a reduction in income, 72% of them. A lot of people suspended CME, or they have a significant reduction in CME because now these conferences are all being virtual. Or you furloughed employees, and sometimes it's not the provider who you furloughed, but it could have been the nursing staff. And so your staffing ratios have changed. And people are thinking, what do we bring back now in 2021 after having this, all these cost cutting that we did in 2020? What should we bring back? Can we run leaner than we did before? I was working with a hospital in the south of Georgia where they'd had a significant furloughing, and they realized actually we were probably overstaffed in some areas, so they didn't bring everybody back. But it actually changes the provider dynamics. And without that staffing, providers' productivity is being impacted, and they're having to refigure, all right, what does this mean for my provider compensation? An additional thing is we're having providers consider retirement at record rates. 37%, regardless of age, are looking at retiring in the next year. We're having conversations with providers who are in their 40s who are talking about retiring. If you think about your planning from a recruitment standpoint and from a retention standpoint, most people don't have these conversations with their providers until they're in their 60s. Some don't have it even then until the provider brings it up. And for your overall planning, especially recognizing how supply and demand is being impacted, what are we going to do about this burnout situation and having lost potential providers or providers wanting to cut back in the future? And how does that impact? How do we put it into our contracts? How are we going to recruit going forward? And what is that recruitment going to look like? On top of that, we have providers disengaged at record rates. 69% of providers saying that they feel disengaged. This is for several different reasons, right? Providers weren't included in COVID decisions. Providers didn't feel like they had any options with regards to the decision making. They feel like there's unilateral decisions made about their contract, and then it's handed to them and they're just expected to sign it. And so this contributes especially to that burnout and losing some of our providers. The fact that 32% of providers saying that compensation is something that they're taking into consideration. Providers are saying, I don't make enough money to put myself at risk this way. So we do have providers asking for increases at significant rates. There's also providers who might have been on a certain compensation structure that it wasn't aligned with the overall organization's goals or wasn't clear. There's not good communication there. And if they don't understand that compensation, then they don't know if it's competitive or not. And so they're questioning it. So the providers are the ones raising these issues. And unfortunately, it creates this cycle that we have to, as an organization, break out of, right? We have reduced supply of physicians to be able to recruit, an increase in demand. Comp is then having to go up, which lowers what we're making in the clinic, practice performance, and eventually it's causing a decline in our patient satisfaction and quality of care, which is going to hurt our reimbursement if you are moving towards that value-based reimbursement. So figuring out where can I step into this and break this chain. And part of it is one of the best ways that we see of talking about alignment is stepping in there and actually having the conversations with providers about their remuneration. And it doesn't always have to be an increase in total remuneration. It can be other factors and other things, such as making the contract and compensation more clear. So with that, let's spend the last part of our time together today talking about, what do I do going forward? What is my compensation strategy going forward? So we have some short-term things that we have to figure out immediately if you haven't already been doing it for the past 6 months, right? What are you going to do about this physician fee schedule change? Are you going to maintain the status quo? Are you going to kick the can down the bucket and say, we're going to just base it off of 2020 and we'll figure it out later? Are you going to do, we're going to do 2020 for part of the year and then we'll switch over to 2021, buy ourselves some time because we're busy with COVID? And how are we going to incorporate that into our contracts? Or are we going to make changes right now? Or maybe you made changes in December of saying, okay, we're going to adopt the changes that CMS made, but we're going to adjust our productivity incentives. So maybe you were paying a provider $50 per work RVU for every work RVU over, 5,000. Maybe now that 6,300 is your threshold, or maybe you're reducing it from $50 to $43 as comp per work RVU. Those are things that we're seeing in contracts that are very standard. As long as you're doing the analysis and math to explain it to the provider, that's overall being accepted really well amongst the providers, as long as you're engaging with them as part of the conversation, instead of just expecting them to say, okay, by the way, here's your new contract, right? Show them the analysis, show your work, explain it to them, let them know what is the current financial situation for the organization and why it's so critical. But then we need to step back and say, all right, that's short term. What do we do to plan for the future? This is not going to be the last change that CMS changes for us. Hopefully we never have something, at least in our lifetimes, as significant as COVID, but we see that there's disruption that happens that impacts our provider compensation from that standpoint. So here's a key opportunity to actually, turn some lemons into lemonade here and think, how do I take overall and look at my remuneration, my compensation, and have a strategy around it? And how does that strategy fit with my organization strategy? Are they aligned or are they divorced? Look at where you are right now with your compensation. Does it make sense with how your hospital is getting paid? I am of the opinion I don't pay for things that I don't get paid for. So if the hospital is paid one way and you're paying your providers in a way that is completely divorced from that, that's not aligned. That's not a good strategy. On top of that, let's make sure we think about our overall retention, recruitment, and development plan. And how is this going to have to shift as we adjust that plan? How is compensation tied into that? Are we going to bring in new providers? We have providers that have been here with us for a decade who are paid one way, but going forward, hey, we want to be closer to best practice, but we're only going to apply it to new providers from that standpoint. Am I going to cause divisions within my medical staff here? How do you get everybody on the same page from that perspective? Do you have protective language in your contracts that allows you the ability to renegotiate your contracts when things blow up the way that they have with COVID or for CMS recently? Not everybody does have that protective language. A lot of organizations, there's very standard boilerplate language of, allowing contracts to be renegotiated in the event of the following. But lots of contracts don't have that in there. So realistically, if you said, hey, this big change happened, we need to readjust our contracts, the physicians could have said, no, I don't want to renegotiate the contract. It is as it is. And now you have a breakdown in your dynamics and your alignment with your providers. So for those of you who are thinking about, hey, where am I on this transition from being in a fee-for-service model? I might be under the standard base compensation plus some sort of productivity, but I know I'm part of an ACO, or I'm transitioning over to some sort of value-based payment. How should I make that kind of transition? First of all, I would say you need to know where you're at right now with how you compensate and how far away it is from that value-based payment. Realistically, your compensation should track it within about 2 years, right? 1 to 3 years, depending on how aligned you are with your providers and how deep you are into that compensation model. You're not going to, if you're already getting risk-based payments, but all of your providers are paid 100% base, you are not going to switch them overnight or frankly, in the next 2 years to being at risk themselves. There's a way to do this in increments that don't damage your relationship with your overall medical staff, that you can keep things absolutely aligned. But this is part of that key of putting those strategies together of saying, where is our reimbursement going to be 2 years from now, 3 years from now? When am I going to be at risk? If I can see when I'm going to be at risk, it tells me how should I work back from that to when do I need my compensation to be so that it's following step. And part of that is being really fair to the providers of the first year that you're at risk, maybe with your ACO from that standpoint, where you have some downside risk. You don't want, while you're figuring out that balancing act of how you would do that, to also be figuring it out with the physician. You need to do it incrementally by step. They need to lag by at least a year. You also have to pay attention to what's going on in your specific market in your area. What are the neighboring health systems doing? What are the other rural health clinics doing? What's Integris doing? From that standpoint, because it sets expectations up for your providers as to what they think they should be making. Let's be honest. People talk. People within your organization talk. Family medicine talks to other family medicine. They want to know, why is this person getting paid this way versus another? They talk to somebody who lives an hour away at a neighboring hospital, and they know how they're getting paid. It happens. And so you need to make sure you're well educated as to what are the numbers around in your market. What are the different models of compensation that exist in your market, and how you might incorporate that into yours, or at least know how you're going to have the conversation. If you're recruiting a new provider and they're telling you, hey, but they're paying this way, at a hospital an hour away, can you address that conversation? Do you know why it's different? Do you have a reason for it's different? If you don't have reasons for it, that's something that you could really assess. So what should you do with that, right? If you're sitting here thinking, you know what, I do need to change my compensation structure. I'm not sure what my strategy is. Where should I start? One of the key pieces, if you want a strong alignment with your medical group, is having some sort of provider advisory or action council, who is specifically, one of their specific tasks is to address compensation. Because realistically, I have never had a good experience of, the C-suite. Sometimes, usually it's the CEO and the CFO who sit together and redesign compensation, and then they present it to the physicians. And then the physicians are handed a new contract. I've never once had a good experience with that. However, if you have some sort of council or committee together that you can work hand in hand with the providers who come up and with the compensation strategy, and they should be meeting regularly with a couple of representatives from there are meeting with the board so they understand the larger organization strategy and see how it ties together. It's a really good starting point. It creates that provider alignment and engagement. It's a collaborative model where they can come in for this decision making as opposed to something that's more directive. With that being said, that council should be heavily educated and understand what is best practice and what are compliance requirements, because they're very critical for disseminating out the information to the rest of your medical group and making sure that they can walk side by side of seeing, okay, here's how my current compensation is, and here's how it could change. Because one of the big things is you want to be able to make sure you minimize the negative impact to your providers and show them how it creates additional growth opportunity for them. Show them how they can win under the new model, right? If they just come in and say, hey, all you're trying to do is give me a pay cut, that's not going to go over well. A key thing also when you're working with this is making sure, how can you simplify your contracts? How can we make sure they're straightforward? Make sure that they incorporate all the different kinds of compensation or remunerations the provider is getting. I can't tell you how many organizations I go into and I see this contract and it seems simple. They're paid, X dollars per visit over this, after I hit my 4,200 rural health clinic qualifying visits of that threshold, I get $100 per visit, whatever the number is from that standpoint. It seems really simple, but as you dig in and you start interviewing people in HR and you interview payroll and you interview the practice administrator, you're like, oh, but they also get this for chronic care management. Oh, they get this for the nursing home. They get this for rounding at the hospital. That's not in the contract anywhere, but it ends up on the W-2. So if you're sitting down and showing us side by side to the provider of here's what's currently in your contract and here's what we're going to do going forward, if you can't show that reconciliation and the provider is the one who's bringing up, well, what about this and what about that? I'm paid for this. then you're going to have you're already behind. You can put bad data in front of providers 0 times, right? Before you've lost your credibility. So understanding, hey, make sure everything is in the contract. And before you go into set what the changes are, make sure you understand all the different components and figure out how can we simplify this? How can we get everybody on the same page? So we know that the execution of our contracts actually fully is integrated with what is actually said in the contract. Right? Make sure the incentives are transparent. It is key that the provider can do their own math to understand what they're making and understand how it ties to the overall organizational goals. It shouldn't be senseless. You shouldn't be giving them quality metrics that they feel like, I can't even impact this. Why am I being paid that way? Or I have no way of tracking this from that perspective. You don't want things to be so subjective where it feels like, hey, it's completely subjective for the CEO to decide how much you make this year. Be very, very clear and transparent with regards to that compensation. As I said, as we're moving over from fee for service, you can see here, if this is the transition for compensation, you see how that lines up with fee for service, moving it over into some sort of value-based model. We started out with years ago, hopefully not too many people are still in this bucket, of just a base salary, and you get benefits, base salary and benefits, other than the first couple of years of a provider ramping up. So most of us are here where we have the base salary plus some sort of productivity. But as we go and transform over in our contracts, you're going to see increasingly variable compensation. You're going to see the providers move from bonuses, say quality bonuses, to being actually at risk for their performance, doing true patient panel management for the primary care providers, where that can go up and down based off of whether or not you're having good clinical outcomes, or tied to some sort of ATO dollars. So in wrapping up, because I do want to leave a minute for questions, is I'd like to think about your contracts and your compliance from that perspective as simple as washing your hands. You need to do it all the time. It has to have consistent documentation. Don't be in a situation where you have, you ask me to come in to help you out and you're like, oh no, I have no idea, that we haven't looked at our contracts in at least 10 years, 5 years from that standpoint. Have your guardrails in place for where are the different parameters of, hey, this is when I'm going to review my contract, even if it's not up for renewal. If productivity, and compensation are more than a 20% variance between one another, am I at a high risk for maybe paying inappropriately from that standpoint, or maybe needing to give a provider a raise and I have a retention risk? So you can identify which ones are your high risk contracts, and having a tracking system for saying, okay, this contract is now switched over to high risk, I should pay more attention to it. Have a policy in place for how frequently you're going to audit your contracts and make sure, am I getting everybody on a similar contract? Where are my old contracts that are up for renewal and I can get them better to my standardized template? And make sure your contracts are actually being executed the way that they are written. If they're not, if what you're paying doesn't match the contract, make sure you get the contract updated from that standpoint. So with about a minute left, I'm going to go ahead and stop there because I know that this was a lot to digest for a lot of people, especially a lot of regulations, and see what questions people have. And to be clear, if you think of if you're reviewing this later on, feel free to email me, or you can email Laura and she can get us a list of questions that we can address.
Yes, real quickly, if anyone has a question, feel free to unmute yourself, or if you want to just type it in the chat, I can read it out loud there as well. All right. Well, thank you, Opal, for your time and all of the great information. Thank you all for joining us. And again, we will have this recorded. If you do run across a question or concern, please feel free to email me. I will definitely send it on to Opal or Greg. And also, we are planning and scheduling our next upcoming RHC webinar. So please check your email in the coming weeks to see when the next scheduled webinar will be. Again, thank you for your time, and y'all have a great day.
Thanks, everyone.